Testing, testing, 1, 2, 3. Testing, testing. All right, folks, 12 o'clock on my count, but we'll give it a few more minutes. I would ask while I'm presenting, for some reason, it's popping up on my end to admit people from the lobby. If you're also seeing this, please just kindly hit admit. Otherwise, I'll try to capture them as I'm talking as well. We'll get started just a few minutes after the hour.
And you're saying that they do before COVID all the time? Yeah.
All right, folks, I got 12:03 on my end, so I think it's fair to get started. And what we'll do is we'll see some people trickling in. I spend a fair bit of my clinical practice time talking about managing COPD, so I thought it was only fair that we just keep the momentum going. But I've changed the title, just a little bit of added in some new content as well, because in the modern era where COPD is managed with biologics for those with frequent recurrent exacerbations, I hope to implore upon you that single inhaler triple therapy is just the start. So we're really focused on single inhaler triple therapy as just the start of pharmacologic therapy in COPD. So this is not meant to take the whole hour today. For those of you who are in attendance now or watching this after the fact, please do not forget to log this for your MOC credits after the presentation, because of course that deadline is coming up at the end of this month. My disclosures here as follows, similar to previous presentations. I do work for essentially every pharmaceutical company in the country that manufactures or is in the respiratory space, as well as designing content for CME for local, national, and international use. Objectives wise, I'm going to go through the entire continuum of COPD management, from screening of a patient population at high risk COPD, management with respect to diagnosis, risk stratification, initial pharmacotherapy, management of exacerbation, vaccination, management of chronic bronchitis, some additional things that your friendly neighborhood respirologist can do, such as Daxis or chronic azithromycin, and biologics. And this seems like an awful lot to cover in 1 hour, but I'll break it down into some of the key concepts. So that from a practical perspective, what your friendly neighborhood respirologist will do, but also what you are able to do, because for our colleagues in primary care, general medicine, as well as for our subspecialty colleagues who see patients with a current or former tobacco history that may be a contributing cause for your organ and expertise, there is an overlap with respect to that as the genesis of COPD and other pleiotropic manifestations of underlying current or former tobacco use. And when I'm sharing with our primary care colleagues everything that we can do for COPD, you do not need a lung doctor for everything that is not in yellow. Screening, diagnosis, risk stratification, initial pharmacotherapy, vaccination, management of chronic bronchitis, exercise. You don't need a respirologist for this. You do need a respirologist from additional you can add on, as well as for biologics to prevent exacerbations of COPD. But your friendly neighborhood primary care and general internal medicine colleagues are very capable of doing everything up until that point. So let's start from the beginning. For those in hospital, first of all, I'm speaking to a hospital group here. All COPD exacerbations, even if you just have a concern for concomitant COPD, if you scratch your head wondering, could this person with a 20, 30, 15, 10 pack year tobacco history and a history of respiratory symptoms presenting with an element of respiratory symptoms or a condition, for example, congestive heart failure, coronary artery disease, vascular disease, sarcopenia deconditioning, manifesting characteristics that we see in COPD. Could they have COPD? Please refer to respirology. We have respirology consultants at all three sites available 24/7. Discharge is hectic. Discharge from hospital is complicated, and you know what the pressures that we have. Discharge tends to happen with a great degree of haste. And referrals at the time of discharge can be missed and forgotten. And it is not uncommon that in the office, when we contact a patient who was referred at discharge, the patient has no idea that the referral was made. They believe it is not required. They often will decline the outpatient appointment. If discharge is not delayed, it is far easier for the consultant to see in hospital, connect with the patient, even if this is a brief consultation, establish outpatient follow-up and testing, close the loop. If the patient already has an outpatient respiratory specialist, that's fantastic. The consultant will see, connect the dots, explain the rationale, ask them to follow up with their outpatient colleague. Straightforward. If they do not, that consultant should become the respirologist. The consultant should populate the after visit summary patient instruction section with their office information. I'll touch on some of this at the end of the presentation. And please refer to the Birchmount Hospital COPD clinic. We now have a COPD clinic at the Birchmount site every Friday morning from 9 to 12. Is an excellent opportunity for patients to be assessed, for there to be a one-time visit, and for that patient to be assessed for readmission and urgency. When we're looking at risk factors for COPD admission, I do want to highlight that there are a number of factors that lead to readmission, but I want to emphasize, even when I was in a position of responsibility, so to speak, discharge planning starts at the time of admission. But there are some key factors that lead to readmission to hospital. When we break down readmitted COPD at the SHN, it is usually a Friday or late in the week discharge with a bounce back early in the next week. It tends to be older adults, males, with limited social supports. The literature will tell us that the greater the severity of COPD in terms of gold stage, dyspnea or resting or exertional hypoxemia, increased history of exacerbations, previous pneumonia, and significant comorbid conditions, these patients are more likely to bounce back. And this is intuitive because there are more pieces of the puzzle that, like a Jenga tower, are ever so vulnerable and stable to a point. And unfortunately, it topples. But that older male phenotype is a high demographic risk for returning to hospital. The deconditioned individual is a high risk. Remember that COPD robs you of your existence, your independence, your identity slowly with the passage of time. And if you learn to live within the limits of dyspnea and your dyspneic threshold, you may feel that ostensibly you are well and stable. If you start to push that threshold, that is where you start to hit a dyspneic limit. An exacerbation of COPD is a subjective deterioration from baseline. If the patient fails to have a true understanding of what baseline is, if the patient tries to attempt activities that push beyond usual baseline physical activity and starts to hit new symptomatic threshold, it'll trigger an exacerbation. Sometimes what we consider a readmission with another exacerbation is, in hindsight, them pushing the limit of their physical and functional capacity and pushing the limit of their symptomatic threshold, manifesting as what we consider an exacerbation, but not entirely so. And of course, add to that social psychological factors, depression, physical and social isolation, lack of caregiver support. If family is involved, or friends are involved, or those who wish us well, the patient might leave hospital on a Thursday or Friday, and the weekend brings people coming to see them, friends and well wishers. However, for those individuals, Monday brings regular daily life, and now the patient is alone again. And it doesn't take much, 24, 36 hours of that, to feel going back to hospital. Similarly, longer length of stay leads to worsening deconditioning, sarcopenia, and decline in physical and functional capacity, such that returning home is a challenge because you cannot return to your activities of daily living. Similarly, for longer systemic steroid use, and I'll touch on that. Friday discharge. Planting the seed of discharge starts at admission, and that late in the week discharge is always a challenge. For the COPD clinic at the Birchmount site, if you go to orders, future outpatient, and you search for hospital respirology clinic or respirology clinic, you'll be able to create an internal referral to the Birchmount site. You have a couple of questions to answer here. You do have to have a spirometry order at the bottom. So after completing that future outpatient order for hospital respirology clinic to the Birchmount site, you will then create one for spirometry with a flow volume loop, accept both, and sign. And at the end, I'll share a number of smart phrases with you that you can use and keep for yourself to put into your after visit summaries. We talk about COPD an awful lot as respirologists, not because we don't have anything else to do, but because the impact it has on patients. 1 or 2 hospitalized exacerbations in a year, and half of your patients are dead within 5 years. Give them 3 or more, and well over 70% are going to be dead within 5 years, well over 50% at the 3-year mark. Even if you manage an exacerbation as an outpatient, moderate in your office, 1 event increases your risk of hospitalization by 20%. 2 events increases your risk of death by 80%. Now here, I have death risk as a percentage increased risk. And on the left-hand side, I have a figure from 2005 highlighting mortality. I wish I could tell you that mortality statistics had actually improved. Updated data 1 decade later in 2014 tells us that 20% of patients with a COPD exacerbation requiring hospitalization for the very first time will die within 1 year. 1 in 5 patients with COPD dying within 1 year of their first hospitalization. The bulk of this is respiratory mortality. A minority is cardiac mortality, but that is now emerging as a modifiable and often significantly underestimated cause of mortality after having an exacerbation of COPD, the cardiac cause. But the Ontario data is more shocking. And now this is a little bit older, unfortunately, but if you're 65 plus and you're admitted to hospital in Ontario for the very first time because of an exacerbation of COPD, 27% will die within 1 year. 1 year mortality is 27%. So we take exacerbations of COPD requiring hospitalization pretty seriously because the mortality risk is not insignificant. And we aggressively escalate pharmacotherapy in the office because the risk of having a severe exacerbation and the future risk is not insignificant. The frustration, though, is that like most things in modern medicine, even though we have excellent treatments that can be used up front to alter future trajectory, most of what we see is event-driven. Something has happened, or something has deteriorated from a baseline that triggers an assessment. Patients will often say, I didn't have COPD until I had that very bad pneumonia that required an emergency department visit. Well, unfortunately, the lung has redundancy. There is excess lung tissue. I see this because I have patients who live a relatively normal life with a pneumonectomy and yet are missing 1/2 of their thorax when it comes to lung anatomy. And yet that individual who has a bad pneumonia and then embarks upon a path of investigation triggered by a conscientious physician to say, let's see if there is something else going on. You find that something else. And that something else, underlying COPD, has been allowed to progress in the background for quite some time. This is not unique to respiratory medicine. This is amongst all internal medicine specialties. I wish we could talk about this being very upstream and proactive, but the best way is to screen. So rhetorical, of course, because this forum is this modality of presentation doesn't make well for a multiple choice poll. But 5 options here. 52-year-old gentleman, 40-pack year tobacco history with morning cough and sputum. 41-year-old female with a 12-pack year tobacco history, dyspnea doing laundry, changing bed sheets. 72-year-old female, a cardiac history, coronary artery disease, hypertension, AFib. Occupational history, though, working as a restaurant server with decline in exertional functional status. Normally, when I present this to a younger primary care patient population, they say, what does the restaurant server have to do with the history? And they forget that there was an era where you could smoke extensively to your heart's content and beyond in restaurant environments. So there's the key there. 45-year-old gentleman, 30-pack year tobacco history, recurrent colds going to the chest, more so than family members. And a gentleman from Asia, hypertension, diastolic dysfunction, immigrated in 2022 with exertional intolerance and wheeze with exertion. There are clues in each of these cases that indicate screening for COPD is warranted. Tobacco history with morning cough and sputum. Tobacco history with exertional dyspnea with activities of daily living, laundry and changing bed sheets. Exertional decline in functional status, exertional intolerance with a secondhand smoke exposure, colds going to the chest more so than family members, and wheeze with exertion. This is codified in the Canadian Lung Health Test, a very simple 5-question screening tool for COPD. If the patient in front of you is 40 or older, they're a current or former smoker, 10-pack years, that's it. 10-pack years means for the average individual, a few cigarettes a day, 5 a day, let's say, for the typical working life of someone working from age 25 to 65. They're a 10-pack year smoker. So even a little bit of smoking, you can see, turns into a risk for COPD. You have to ask them 5 questions. The questions are stacked in order of likelihood of someone saying yes. You only need to ask 1, yes, and you order lung function testing. Do you cough on a regular basis? Cough up phlegm on a regular basis? Simple chores make you short of breath? Do you wheeze with exertion or at night? Do you get colds that persist longer than people you know? Rarely do I get to the colds that persist longer than people you know or the wheeze, because cough, sputum, dyspnea, ubiquitous, common in the setting of COPD. Please order a pulmonary function test. If you see this person in the office, refer to Respirology for screening for COPD. This is high yield. You have a 1 in 4 chance of a new diagnosis of COPD. That is very high yield from a screening standpoint. But let's turn our attention to cardiac comorbidities. This is ever present. It is still number 1 and number 2 leading cause of death on this planet with respect to cardiovascular disease, myocardial infarction. Granted, COPD is number 3 on that list, so we are not far behind. It isn't a race, but we are up there. If we look at the presence of cardiac comorbidities with or without COPD, you see something that should pique your interest. If you have an individual with COPD, they're far more likely to have hypertension, coronary artery disease, diabetes, heart failure, supratentorial manifestations of depression and anxiety, peripheral vascular disease. All of these cardiac comorbid conditions are at a higher prevalence in those with COPD than without. Many of these are caused by current or former tobacco use, but oftentimes the current or former tobacco use leads to cardiovascular disease, leads to events and recognition and optimization of management along that line. But the same risk factor, current or former tobacco use, that sparks the genesis of cardiovascular disease can also do the same for COPD. There is a strong correlation between our cardiology colleagues and respiratory colleagues when it comes to current or former tobacco use. And I ask the respirologist, general internist, subspecialist, and cardiologist in attendance to refer to each other. If you have a patient with established cardiac disease manifested with a previous current or former tobacco history, let's screen for COPD. Your friendly neighborhood respirologist that captures COPD in a dyspneic patient should refer to cardiology for assessment and exclusion of these other cardiac comorbidities. There's synergy here. We should remove the family doctor from having to make these referral decisions, do it ourselves. Family doctor stays in the loop, but we initiate, co-manage, and share these patients amongst ourselves. Because if you have cardiac manifestations with a current or former tobacco history, you're more likely than not, to have underlying COPD. I made allusions to the title that single inhaler triple therapy is just the start. And I say this because in the event driven, be it exacerbation, declining symptoms, new or worsening symptoms, most of what we capture in the setting of COPD is going to be high risk, frequent recurrent exacerbations, or high risk in terms of symptom burden, where initiation of single inhaler triple therapy from the get go is not unreasonable. Let's walk through this. When we're looking at dyspnea, modified MRC class 2 dyspnea is considered high risk. Anything worse than that, you're still high risk. Class 2 is such that if you're walking around Scarborough Town Center at your own pace, you have to stop because of shortness of breath, or sneakily, because patients are sneaky, you have to slow down to avoid having to stop, or you can't keep up with an age-matched peer. Hopefully all of us are modified MRC class 0. Only on a treadmill, extreme exertion, do we have shortness of breath, but we never have to stop because of it. Some of our patients are class 1, hurrying on level ground, climbing a gentle hill. They experience dyspnea, but they do not have to stop. If you have to stop because of dyspnea or can't keep up with an age-matched peer, you're high risk, class 2. Class 2 is not uncommon. Look around the world and you will see that around half or more of patients with COPD in the wild are class 2. If you're a betting person, there is a 50% chance that the person in front of you is not a mildly symptomatic patient with COPD. They are a symptomatic patient with COPD. And they may acclimatize to it and alter their activity to avoid experiencing the symptom, but they are symptom limited. What about severity of COPD from spirometry? On the right, we have two cohorts from primary care, one from 2007, one from 2008. If you actively screen for COPD in primary care, only 20 to 30% of the COPD you capture is mild. 70 to 80% is not mild. Our guidelines say if you have not mild COPD, moderate, severe, or very severe, your post-bronchodilator FEV1 is less than 80%, you are high risk. So we know that at least 50% of patients are high risk when it comes to their dyspnea, and 70 to 80% of patients are high risk when it comes to the spirometric severity of COPD. The next part, exacerbations. Follow patients long enough and they will exacerbate. 77% of patients in the ECLIPSE cohort had a moderate or severe exacerbation within a 3-year period. And regardless of the study you look at, whether it's Spiromics from 2010 or the Uplift cohort that takes us back to 2017, or 2008, or the ECLIPSE cohort, we have an element of exacerbations that occur with the passage of time. Follow patients, and they will have exacerbations of COPD. But here's the kicker. In a 6-month study in Canada, just focusing on Canada here, with 421 patients, they were monitoring for exacerbations. They counseled the patients on what to look for with respect to exacerbations. 68% of patients had an unreported exacerbation. So even if patients have an overt exacerbation that they report to you, patients with COPD will often have unreported exacerbations, these periods of significant lung function decline that occur in the background that they fail to recognize, fail to escalate, fail to treat, but that has a significant prognostic and phenotypic impact. Wrap all of this together, and when we're looking at exacerbations in the previous 12 months, these periods of increasing dyspnea, sputum volume, sputum purulence, high-risk individuals are those who are dyspneic, not with mild COPD, and have had 2 or more moderate or 1 severe exacerbation in the previous year. They start and finish with triple therapy. Triple therapy is the beginning and the end of their inhaled pharmacotherapy. We only add from there. Even if a person has had just one outpatient exacerbation in the previous year, and the recommendation is to initiate what we call dual bronchodilator therapy. I will tell you that in clinical practice, when we start dual bronchodilator therapy, within a short period of time in follow-up, that patient presents a new level of exertional intolerance and limitation such that dual bronchodilator therapy is not enough. And many of us, recognizing what the future holds, the impact that exacerbations have, and the benefit of triple therapy of preventing that, initiate these patients on triple therapy up front, recognizing that a symptomatic labile patient with COPD may feel better on dual bronchodilator therapy initially, but in follow-up, likely to have suboptimal control, likely warranting escalation of therapy. Triple from the start. Our guidelines tell us that if you have two moderate office exacerbations or one ED visit or worse in the previous year, dual bronchodilator therapy maximizes management of dyspnea. The ICS plays a further role of exacerbation reduction, and it's triple therapy from the start. I will not fault any of you for initiating triple therapy from the start, because by virtue of where we work, if you see symptomatic exacerbating COPD in a hospital environment through the doors of one of our 3 sites, that is triple therapy from the beginning. But we're now in an era where many of our patients are already on triple therapy. So what else can we do? Well, first, when we're talking about the triple therapy options, we have Trelegy 100 and Breztri. And the reality is there a difference between the two? If you look at the clinical trials, and I've spared you from all the figures and tables, but the 2 landmark clinical trials, Impact and Ethos, have a similar table 1, a similar primary outcome for reduction of moderate or severe exacerbations. One was 25% reduction, one was 24% reduction. If the patient is prescribed Trelegy or Breztri, they can utilize the device effectively, they do not have intolerance of the device, and they follow the prescription as it is written, like gospel, they should have a similar reduction of exacerbations. But real world is not an RCT. Breztri is twice a day. Trelegy 100 is once a day. Sometimes patients have challenges utilizing a drug twice a day, and a once a day therapy is more effective. We have to educate our patients that COPD is a lifelong, chronic, permanent, progressive, obstructive lung disease. It ain't going away, and it is going to progress. And this medicine is lifelong. So if they have the inclination of weaning off the medication, I want to wean off of it so I'm not dependent upon it, you are only going to do yourself a disservice. Trelegy is 1 puff once a day. If you don't take it, you know you took 0. To control my triglycerides, for example, I'm on Vasipa. It's 4 pills a day. Maybe I might miss the evening pills sometimes because of where I am or what I'm doing. But I say to myself, I still took 2 of them, so I got something. But my Crestor is once a day. And if I miss it, I go to bed knowing I forgot it. And I go and I take it. So once a day, if you get none, you got none, you know it. But if Breztri is 2 puffs twice a day, sometimes patients do feel the inclination of weaning off medications. Education and counseling should prevent that. It's 2 puffs twice a day. That's not up for negotiation. But if you do not feel that you could do something twice a day, you prefer once a day, I have options. Trelegy is a dry powder. Breztri is a meter dose inhaler. You should not feel the medication. If you taste it, you feel it, your vocal cords are hoarse, the medication is not being effectively inhaled. If it's a dry powder inhaler, they should not taste it, feel it, or it should not affect the vocal cords. Education can address that. If it's a metered dose inhaler, they should be using it with an aero chamber. Aero chamber does not do much with respect to further increasing lung deposition in the setting of good technique. Slight improvement. But what it does is minimize oropharyngeal deposition and minimize the adverse effect. We also have to counsel them that these medications really are designed to prevent exacerbations. They may improve lung function. They may make you feel a bit better. But if you don't feel better, do not stop the medication. I'm prescribing it to attenuate the likelihood of future events. not necessarily to make today or tomorrow feel better. If it does, that's a win. But the real intention is attenuating the risk of future events. Like most things in life, chance favors the prepared mind. And you can be smart, but it sure is more effective to be fast, to be first. When we're looking at initiation of triple therapy, prompt initiation in hospital is key. Regardless of whether you look at all-cause readmission on the left, COPD-related readmission on the right, if you initiate single inhaler triple therapy after a hospitalized exacerbation within 30 days, 60 days, or 90 days, or delayed beyond those marks, delay of triple therapy has a higher risk of readmission. This is bad for the healthcare system. This is bad for our patients. This is bad for the system as a whole. I can't say that prompt initiation brings it to zero. I wish it did. You still get a 20% rate of readmission in the literature from COPD and a little bit higher from all cause because these are very sick, comorbid patients and things decompensate when they're admitted to hospital. But they're less likely to bounce back, less likely to come back if they left on triple. The data shows that 14 days is better than within 30 days. And in fact, I'm working at the level of the Central East LIN to ensure that our COPD admission order set has a forced function. You must pick a single inhaler triple therapy. COPD admission, hospital visit, triple from the start, Trelegy 100 or Breztri. Started on admission, they learn, they also associate that this event that happened is associated with this change in medicine designed to prevent the event. Compliance goes up when an event leads to a change that prevents that outcome. They're more likely to embrace it. When you're looking at once a day versus twice a day, this is intuitive. Something that's once a day, I brought up my own Vasipa Crestor example. Once a day is far more likely to maintain adherence than twice a day, and the literature supports this even across age groups. But I want to highlight this data from Trelegy and Breztri. Now, everything I've said is built up to this slide of once a day being better than twice a day, one puff once a day being better than two puffs twice a day. But at 12 months in this Japanese study, looking at patients with COPD newly started on Trelegy or Breztri, the disappointing aspect is not the fact that things were 43% better if they were on Trelegy versus Breztri, so once a day versus twice a day, but that even for Trelegy, persistence using more than 80% of doses was only 35% of patients at the end of 1 year. This is an education gap. Compliance with pharmacotherapy is paramount. And when patients understand just a couple of sentences that this is a permanent, irreversible, incurable, progressive obstructive lung disease with a risk of hospitalization, risk of chest infection, and risk of death, that collectively, folks, is how we can move the needle of ensuring that 1 year compliance is superior to what we see right now, which is 35%. So, which patient profile warrants single inhaler triple therapy? The frequent exacerbator. 2 or more outpatient exacerbations in the previous year in our office, even 1 emergency department visit, hospital, ward, or ICU admission. If the patient is on anything less than triple, like dual bronchodilator therapy, Anoro, Inspiolto, Ultibro, if that is not enough to control symptoms, and this is entirely subjective, or symptoms become uncontrolled despite being on it, or they have an exacerbation, escalate them to triple, Trelegy 100 or Breztri. If they're on multiple inhaler triple therapy, do a favor, consolidate. I have yet to have a patient complain that, you know what, 6 puffs a day, I like it. I'm happy with that. I do enjoy 2 inhalers, 2 different techniques, 2 different times a day, 6 puffs. If I can convert that to 1 puff per day, eyes widen, they are happy. I've improved quality of life right there and then. Not every patient can tolerate single inhaler triple therapy. So your friendly neighborhood respirologist does have patients on open triple therapy. We do that grudgingly, however. We try Trelegy, we try Breztri, and if they fail, despite our best efforts in education, we have open triple therapy. But it is not for lack of trying. If we do this, if what I presented thus far is followed, We can, on average, over the next 10 years, by implementing the 2023 CTS guideline, extend patient life by 1.7 years. We can avoid around 180,000 deaths and reduce the mortality rate from COPD over the next 10 years by 22% and save the system $3.5 billion. Now, granted, the federal deficit this year is around 100 billion, so 3.5 billion is a drop in the bucket, so to speak. But nevertheless, every dollar counts. And if we can improve the fiscal health of the system, the mortality rate, and extend life on this planet for our patients with COPD, that is a win. And it comes from practically taking the evidence that we focus on of single inhaler triple therapy and applying it aggressively to patients with symptomatic exacerbating COPD. So let's talk about the exacerbations. Exacerbations of COPD. The biggest reason for hospitalization outside of pregnancy. Number one cause of admission to hospital for an adult in Canada, pregnancy. Number two cause, exacerbations of COPD. COPD, biggest reason for hospitalization outside of propagation of our species. They manifest as a subjective deterioration of patient symptoms with objective manifestations generally of infection. The patient will notice increasing dyspnea. They will have subjective increasing sputum volume. They will have objective evidence of sputum purulence. This, of course, has a negative impact on patient health. Like most things in life, the best indicator of future behavior is past behavior. The number of exacerbations in the previous year is a reliable predictor of future events. There's some other factors, though. The severity of COPD heralds a higher risk of exacerbation and higher number of exacerbations. Chronic bronchitis is a big factor. Remember that an exacerbation of COPD is not a weird or wonderful bacteria coming into the chest. The most common sputum culture result in the setting of an exacerbation of COPD is normal respiratory flora. Something happens to disrupt the balance of higher burden of bacteria. The microbial milieu in COPD has a higher burden of bacteria per unit volume. Something disrupts that balance, leads to an overabundance of one versus another, triggers an exacerbation. Gastroesophageal reflux can have a cholinergic mechanism of increasing mucus production within the airways, but also this inoculation of a bolus of acid, if it is quite overt reflux, especially nocturnal reflux. Think of our patients with sleep apnea, where the glottis is closed and you actually have absence of air flowing into the chest and negative pressure within the mediastinum that can lead to reflux events. You can actually inoculate acid that leads to that injury that then leads to disruption of balance, triggering that exacerbation. The best indicator that it is bacterial is purulent sputum. My infectious disease colleagues on the call will probably not be happy with this, but we have a low threshold as respirologists for prescribing antimicrobial therapy. Who would have thunk it, right? Purulent sputum is one of the best indicators amongst many poor indicators, and it's poor in itself. But in terms of predictive factors, purulent sputum, the best that we have that it is infectious. If there is purulent sputum, antibiotic plus prednisone indicated. Sometimes you will see increasing volume of sputum, and it's clear. You will see increasing dyspnea, and we will treat these patients with prednisone only. They know to activate only that side of their action plan. But when they have purulence, antibiotic and prednisone. So for those managing acute exacerbations, please use Ventolin. The beta receptors are upregulated in number and density during exacerbations. These patients need Ventolin. It's fair to consider Atrovent, but only to a point. Long-acting muscarinic antagonists that are present in dual bronchodilator and single inhaler triple therapy bind very strongly to blockade cholinergic receptors. Now, cholinergic receptor density and number doesn't fluctuate to the same extent in the setting of exacerbations. So if the patient can still reliably use their controller with a long-acting muscarinic antagonist, think single inhaler triple therapy, Atrovent on top of that will probably just lead to some adverse effect. The challenge, though, is that in the setting of an exacerbation, I can't guarantee that Trelegy and Breztri are getting into the chest 100%. So often in the first day or so, we will add some Atrovent on, but then quickly eliminate it and stay with controller therapy and Ventolin because we want to avoid short-acting muscarinic adverse effects. Prednisone. Again, we're not treating vasculitis. Prednisone has an indelible impact on head-to-toe function and risk factors for avoidable steroid-related comorbid conditions. 5 days, 40 milligrams. You can always give them more. Some of our older patients, if there's a concern for relative adrenal insufficiency, very fair to have a taper. Sometimes I'll do 40 for 5, 20 for 3, 10 for 2. And patients do feel that that is better to come off that higher dose, but 40 for 5 is sufficient and is equivalent to 14 days for repeat exacerbations and lung function at 6 months. And antibiotics as well, 5 days are very reasonable. Sometimes the patient will have bronchiectasis. You may see this because the CAT scan report comments on it. You may see this because it's in their chart, or they might have a very high burden of bacteria at baseline. Antibiotics are bullets. Bacteria are the targets. If you have more targets, you need more bullets. You don't win a war rationing ammunition. 5 days may not be sufficient. You can always extend, but some patients with underlying bronchiectasis at baseline or with a higher burden of sputum volume and purulence at baseline due to that milieu will often benefit from a longer course, let's say 7 or 10 days. But it is better to learn this after the fact as opposed to a longer duration of antibiotics from the get-go. Options: mild to moderate COPD as an outpatient, azithromycin and doxycycline, but for many patients that you'll see in hospital, clavulin for 5 days or Avelox. My preference is clavulin. If they have a penicillin allergy or intolerance, Avelox is there, but risk of C. difficile, and also I've had a couple cases of near tendon rupture, tendon injury, and not full spectrum rupture. So we tend to try to avoid fluoroquinolones if we can for this basis. Here's something interesting that I haven't shown with you previously. Everyone with any respiratory symptom walking into the hospital gets a CT pulmonary angiogram protocol. As someone who looks at lung pathology and sees referrals for patients with lung pathology, my sincere gratitude to the emergency department physicians for generating more referrals for incidental findings that have very little in the way of prognostic impact or negative impact, I should say, for a patient. But there is something to be said for mucus plugs. You probably see this in the body of the report, maybe not in the summary, but in the future, you will start to see a discussion more and more about mucus plugs. Mucus plugs are these gnarly, desiccated, rather immobile, and rather fixed, obstructive plugs that sit within the airways. If the radiologist counts the number of segments of the lung that have a mucus plug, what we see fascinatingly here for patients with COPD is an increased risk of mortality. This was a retrospective study. Patients had a single CT scan of the chest. They had COPD. They had a single CT scan of the chest, primarily to look for pulmonary nodules for lung cancer screening. And they identified mucus plugs. They then followed that patient for 12 years. Those that had a higher burden of mucus plugs, look on the y-axis, the risk of death. 3 or more mucus plugs, 60% dead at 12 years versus a little under 40% for those without mucus plugs. Mucus plugs, as a reflection of airways inflammation, epithelial dysfunction, will be a prognostic marker in the future that may target intervention and target energy of preventing mortality in patients because it indicates an epithelium that is highly dysfunctional and leading to these production of thick, gnarly, and desiccated plugs that block airways. Ignore the lung function impact. They have a clear prognostic element. And we can go one step further. Let's talk on the right side first. On the right side in blue, we're looking at mucus plugs based on GOLD severity. So on the y-axis in blue, GOLD stage 1, 2, 3, 4. 1 is mild COPD, 2 is moderate, 3 severe, 4 is very severe. You would think that at a higher level of spirometric severity, GOLD 4, you would see a higher proportion of mucus plugs. The color does not indicate that. In fact, we would see that there really isn't a correlation between spirometric severity and the prevalence of mucus plugs because it should be dark blue in the top right and light blue in the bottom left. But let's go to the left side. Here we're looking at all-cause mortality. Darker red is, of course, worse. The x-axis is the number of mucus plugs, just the number of segments. 3 or more, they stop counting. And then spirometric severity on the y-axis. Now we see a correlation. Combine mucus plugs and spirometric severity of COPD, and you see a strong correlation of an increased risk of mortality. Again, this was a 12-year study. You're going to see this emerging. So when you see a mucus plug on CT scan and you see a history of frequent recurrent exacerbations, we are now in the biologic era, and there are things that we can do as respirologists that can further reduce the risk of exacerbation. Let me touch on that. But first, let's go back to basics again. Vaccines, please talk about vaccines. If you do not prescribe them yourselves, please put it in the note. Tell the family physician that this is indicated. Influenza is covered by the government for all. I'm talking about adults here. COVID-19 covered for all. Arexvy for all 75 and older. You and I can't prescribe it for someone 75 and older. The family doctor has to get it from the public health unit and administer. This is cost control from the level of the province because it's a silly system. I would love to keep prescribing it for those 75 and older. If they're 60 or older, ALC in hospital, retirement home, long-term care, elder care lodges, it is covered by the government. There is evidence for those 18 plus. So I can tell you that I myself have been vaccinated to prevent RSV because there is evidence for those 18 plus, and soon we'll have Health Canada indications for both. We have it for Brisvo, it's coming for Arexvy for 18 plus. Prevnar 20 is recommended and covered for those 65 plus, but recommended for high-risk individuals 18 plus. Flu and COVID are every year. RSV and pneumonia, one time only. You get it, you're done. There is no need for a booster. We may have better versions of the vaccine in the future, so we get that in the future. We upgrade. But at the end of the day, one and done for these. Tetanus, of course, Tdap is every 10 years. Shingrix, again, provincial cost containment. Shingrix is covered for those 65 to 70 only. But the Health Canada recommendation is 50 plus. Risk of shingles really starts to take off at about age 40. It really starts to jump at age 50, but recommended for all 50 and older. There is evidence for mitigation of adverse outcomes in COPD for each of these. So let's talk about viruses and pneumonia. This is a very interesting study from 11 years ago in JAMA. Very elegant study. They looked at individuals hospitalized for pneumonia. Bacterial, viral, co-infection, bacterial, viral, doesn't matter. And they followed them for 10 years to look for the risk of fatal or non-fatal adverse cardiac events, MI, stroke, fatal coronary heart disease. In bold at the bottom, they adjusted for all of these variables, including lung function, including the presence of carotid atherosclerotic plaque, because of course these individuals were in a cardiac study. So this is a subset in that study. But we see a signal, statistically significant, at least for the first 2 years, and then a strong signal, significant unadjusted, attenuated adjusted, of an increased risk of fatal and non-fatal cardiac events for up to 10 years. A pneumonia, an exacerbation of COPD, a significant chest infection is a profound systemic inflammatory event. The inflammation is pulmonary, but that pulmonary capillary bed feeds the entire body. That inflammatory milieu spreads. You know that when a patient is septic and develops ARDS, the lung is the next capillary bed receiving all of those inflammatory chemokines and cytokines. And when the lung is the source of that, it has a systemic effect, and that destabilizes plaque. That increases the risk of fatal and non-fatal adverse cardiac events. My routine, patient admitted to hospital for pneumonia, sending them for cardiac testing to see if I can potentially mitigate and capture early a risk factor that this individual could be at increased risk because by virtue of the fact that they have been hospitalized for pneumonia, they are at risk. Vaccination, folks, flu, COVID, RSV, pneumococcal, shingles, and Tdap, you can eliminate the risk of 40% of viruses and 30% of bacteria right there, preventing pneumonia, preventing infection, preventing exacerbations. Last few minutes, let's talk about exercise. Referring to pulmonary rehab is a challenge. We do not have anything in Scarborough. 800,000 people, no pulmonary rehab. You have three options, well, four. You can send them to West Park at Jane and Eglinton. You can send them downtown to Toronto General or Toronto Western, which is a bit of a pain. You can send them to Toronto Grace, which is at Church and Bloor, still downtown, again a pain. They can go to Whitby. Lakeridge Health in Whitby has an outpatient COPD rehab program that is Brock and 401. So unfortunately, though, in Whitby, we do not have one in Scarborough. Here's what I recommend. 30 minutes a day of brisk cardiovascular exercise. Brisk enough that they can't sustain a conversation. If they're walking with someone, they can get out a sentence 2 or 3, but can't sustain a conversation. Even if they have the inability to do so, 1 hour of television has 15 minutes of commercial breaks. Walk during commercial breaks. There is evidence for reconditioning of individuals when they walk in commercial breaks. This may seem silly, but we often do this. If you watch TV and watch commercials, because you could stream everything, right, and pay for the higher subscription. But if you get up and do something in the commercial, run a little errand around the house, and then come back and continue your show, well, this is what you're doing. You're getting activity during those commercial breaks. It adds up. And for our older individuals who spend, unfortunately, a fair bit of time watching TV, walking during commercial breaks, 2-hour movie on AMC, they'll get 30 minutes of walking right there. Chronic bronchitis. I have two things that I can offer for this: aerobica and N-acetylcysteine. Aerobica is mechanical chest physiotherapy. Specifically, it's an oscillating positive expiratory pressure device. It's a low resistance one-way valve. The patient inhales through it and nothing magical happens. But when they exhale through the device, it vibrates. It shakes the air as you exhale. A smooth flowing river does not pull in debris from the banks. A turbulent river does. Turbulence within the airways shakes mucus loose, vibrates the airway, liberates secretions. It helps to expel and clear mucus from the chest. It's a 10-minute, twice a day at a minimum. They close their lips around the mouthpiece, they inhale and hold their breath, they exhale through the device, and they cough and clear their chest. They can buy it from the pharmacy. It's about $80. They can buy it online from Amazon as well. What it does is it clears up mucus blocking the airways. Xenon MRI on the left-hand side, black areas of the lung are not well ventilated. With 3 to 4 weeks of aerobica, this was a patient after an exacerbation of COPD, they have an improvement in ventilation and regional ventilation. Mucolytic therapy for N-acetylcysteine, patients love this. It's a health food store product. They can go to the pharmacy, they can go to Healthy Planet, they can go to Amazon, and they can buy this. It's an over-the-counter medication. You know it from the antidote for Tylenol overdose intravenously. The total daily dose is 1,000 to 1,200 milligrams. They can buy it at the pharmacy and they can utilize it. We can add other things. Azithromycin, Daxis. This is a bit challenging. Azithromycin has tolerability issues as a pseudo-macrolide, so to speak. Technically, it's a different class, but as a macrolide, it has an element of gastrointestinal intolerance. QT prolongation is an issue. There's an increased risk of tinnitus and changes in auditory acuity. Daxis is not covered by the government. It's $90 a month, and there's an element of diarrhea that can be associated with it. The effect size is meaningful, but these studies are also old. Daxis is from 2009, azithromycin is from 2011. The external validity in the modern era of COPD is not there. This is where we come to biologics. When we're looking at timely intervention with optimal therapy to establish and maintain disease stability, the goal is no symptom worsening, no decline in lung function, and no exacerbations. Everything that we've done up to this point moves us closer, but biologics do help as one step further to take us there. Just for the interest of time, I'll skip this slide. Suffice to say that Dupixent was studied in patients with COPD on triple therapy with frequent recurrent exacerbations, 2 or more moderate or 1 severe, and a blood eosinophil count of 0.3 or higher. 0.3 is not high based on life labs or our EMR, but it is enough of a signal to indicate that T2 inflammation is present. Dupixent in the setting of COPD added to triple therapy has a meaningful improvement of lung function, a meaningful improvement in quality of life, but most importantly, a 30 to 34% reduction of exacerbations. This is what we want. This is far more effective than azithromycin, far more effective than Daxis. And I don't mean to say that you shouldn't add azithromycin and Daxis and Dupixent at the same time. Do as much as you can, and the patient will tolerate to prevent exacerbations. But biologics are the future. And they also attenuate the very underlying pathways that cause obstructive lung disease to progress and to worsen. We now have Dupixent covered. If your patient is on triple therapy, has a blood eosinophil count of 300 or more, they have an MRC grade of 2 or more or MMRC of 1, and they have 2 moderate or 1 severe, check these boxes, and if they qualify, your friendly neighborhood respirologist can initiate. The takeaway here, if you prescribe prednisone to a patient with COPD, we can get them started on a biologic. If you prescribe prednisone to a patient with asthma, we can get them started on a biologic. We assess each case, we assess eligibility, but your prescription of prednisone can lead to our action initiating a biologic. I promised this at the start, and I'm going to share it with you. If you search in Epic under smart phrases, where you would set up your own smart phrase, search for my name. Because when you're populating the after visit summary patient instruction section, if you go to the discharge tab and you're looking at the after visit summary patient instruction section, I have smart phrases for a whole host of things. If you want to refer them to the Birchmount COPD clinic, smart phrase for that. If you're ordering radiologic investigations, I have a pre-filled smart phrase that tells the patient who to call, where to get instructions, how to go about the booking. If you order a PFT, you want to order N-acetylcysteine or Aerobica, I have a smart phrase for that. If you want to refer the patient to the Center for Addiction and Mental Health Nicotine Dependence Clinic to quit smoking, there's a smart phrase for that. So I hope that this has been, I promised that I would finish on early, and normally I run late, so finishing 2 minutes early is actually good. I'll be presenting rounds in April again. The focus there will be what I alluded to at the end, T2 inflammation, that side of our immune system that causes obstructive lung disease to be worse and for deterioration of patients with obstructive lung disease. Enjoy your afternoon. It's Wednesday. It's almost the weekend. If anyone wants to stay and ask questions, happy to answer. But otherwise, have a wonderful day.